Hello, my name is Craig Coopersmith. I'm the director of the Emory Critical Care Center. I'm very sorry that I'm unable to be in Brussels this year and that we have to do the meeting virtually because of COVID-19. But I'm excited to talk to you about how we can protect the gut in critical illness. So my disclosures are listed here. I'm the co-chair of the Surviving Sepsis Research Committee, and I was a co-investigator without pay on two recently concluded clinical trials. So under healthy conditions, the gut has three different parts. There's an epithelium with a surface area of somewhere between 30 to 300 square meters, which is somewhere between half the size of a badminton court and a tennis court. There's an adaptive immune system, and there's actually more lymphocytes in the gut than any other place in the body, more than the spleen, more than the blood, more than the thymus. And there's a microbiome with 40 trillion, with a TR, microorganisms, which is at least as many cells as the host has. And I'm certainly going to come back to this later. The gut in sepsis is often referred to as the quote-unquote motor of the systemic inflammatory response syndrome. And our understanding of how the gut serves as the motor has evolved over the last 30 years. There's a number of different ways. I can't, of course, go over all of them in 12 minutes, but I'm gonna try to give an overview. The first thing I like to do at the bedside is make the distinction between intestinal failure versus gut dysfunction for our patients. So intestinal failure is defined as the reduction of gut function below the minimum necessary for the absorption of macronutrients and our water and electrolytes, such that intravenous supplementation is required to maintain health and or growth. This is relatively rare in our patients. Some of our patients do require TPN, but it's relatively rare. However, gastrointestinal dysfunction is quite common. And what do we see? We see absent bowel sounds, diarrhea, bowel distension, vomiting, high gastric residual, GI bleeding, intra-abdominal hypertension. So how important is that? Well, the number of simultaneous GI symptoms is higher in non-survivors than survivors. While none of these symptoms alone is an independent predictor of mortality, which I imagine everybody listening to me already knows, it turns out that gastrointestinal dysfunction, defined as 3 or more symptoms on day 1, is actually independently associated with a 3-fold increase in mortality. So there's all clinical symptoms that we can see at the bedside. They're not that mechanistic. So we might ask the question, are there other more biologic markers of gut dysfunction? And so if we want to detect gut barrier failure clinically, 2 things that we could potentially measure are plasma citrulline, which is a marker of enterocyte mass, and plasma IFABP, a marker of enterocyte damage. So these are various studies in the ICU of citrulline, again, a marker of enterocyte mass, and in a wide variety of things: cardiac arrest, septic shock, overall critical illness. And in all of them, citrulline is reduced. Similarly, IFABP is increased in a wide variety. So can we use these at the bedside? Well, the answer is probably not yet. This NICE review shows that studies in animals and patients outside the ICU support the rationale for the biomarkers. At the same time, evidence in critically ill patients is not yet convincing. Several aspects need to be clarified, and the methodology and interpretation need to be refined. So there's a good rationale for looking for intestinal injury, but further studies are needed to see whether we can actually use that at the bedside. So let's move beyond that. How mechanistically can the gut serve as the motor of MODS? Well, I mentioned to you the microbiome before. Again, there's 40 trillion different bacteria inside our intestines. This is taking all 40 trillion and bringing it down to a single data point. Red are healthy patients here. Blue are ICU patients. Over 1,300 people. And if you look at them, you see that there's almost no similarity between what the microbiomes of you listening to me right now and what our patients are in the ICU. They look remarkably different. And if you take care of children, you'll see the same thing, that there's a remarkable difference between children and between adults. So what causes these changes in the microbiome? Well, critical illness in and of itself changes the microbiome. The body has alterations internally There's hypoxemia, there's alterations in phosphate levels, and this in and of itself changes the environmental milieu, which changes the bacteria to release virulence factors, which changes the microbiome to a pathobiome. But it's not just the host response, there's also unintentional side effects of our trying to treat critical illness. If we give antibiotics, that will kill off a number of bacteria. That changes the microbiome. If we give opiates, a mainstay of pain control, that changes the microbiome. If we give proton pump inhibitors by changing the pH, that changes the microbiome. If we give tube feedings, in theory, that changes the microbiome. It certainly does outside the ICU, but is understudied in the ICU. Leading to the question, can we actually alter the microbiome at the bedside? Well, there's a number of different things we can do to the microbiome. We can increase the so-called good bacteria by probiotics, prebiotics, or symbiotics. We can transplant an entire bacterial load by fecal microbial transplant, or we can decrease the quote-unquote bad bacteria by selective decontamination of the digestive tract. And amazingly, as different as these are, each of these has been shown to work to some degree. So starting with increasing the quote-unquote good bacteria, these are the numbers on PubMed on the day that I'm lecturing to you, on August 18th, for probiotics, for prebiotics, and symbiotics. And you'll see huge number of references to each of them in general, as well as a significant number of references to each of them specifically in sepsis. So are they effective? Well, these are two meta-analyses, one of them published as recently as 2019, of about 2,000 patients in about 13 trials, both showing about the same thing. They reduce ventilator-associated pneumonia, although not in all trials. They lead to a shorter antibiotic use. However, they don't change length of stay, duration of mechanical ventilation. Most importantly, they don't change mortality, and they don't change diarrhea. However, even though there's multiple studies, they're limited by low quality evidence, by heterogeneity of study designs, and by heterogeneity of outcome measures. This provocative paper came out a couple of years ago looking at neonates given symbiotics to prevent sepsis. So this was over 4,500 infants, at least 2 grams at birth, 35 weeks of gestation, healthy infants, and they were randomized to either an oral symbiotic preparation that you see there or placebo. And there was a significant reduction of neonatal sepsis and death, and you see the relative risk of 0.6. There was also significant reductions in culture-positive lower respiratory tract infections. So further studies have yet to replicate this, and this is a very specific environment where this was done, but this suggests that potentially, at least in some populations, that symbiotics can be impressive. However, these are 2 studies that came out fairly recently questioning probiotics not in the ICU, but actually suggesting that by giving standard probiotics, we actually prevents the actual digestive tract prevents you from colonizing them. And formally, if you take probiotics to counterbalance antibiotics, this can actually delay the return of a normal gut function. These are, again, not done in the ICU, but it does lead to questions about what happens in the ICU. Moving on to stool transplant. This is transfer of intestinal microorganisms from a healthy donor via infusion of a liquid suspension to stool, with the goal being restoring the normal microenvironment. While I understand that that sounds incredibly disgusting, this landmark paper came out earlier this decade showing that comparing oral vancomycin to stool transplant with a primary endpoint of 10 weeks of relapse, the cure rate for oral vancomycin for recurrent C. diff was 30%, and the cure rate for fecal transplant was 94%. And so this no longer sounds disgusting. This sounds amazing. And in fact, a meta-analysis done afterwards of 37 studies, including 7 randomized trials, shows that fecal microbial transfer is way more effective than vancomycin, with a remarkable relative risk in resolving recurrent and refractory C. difficile infection, with a resolution of 92%. Well, you might say oral vancomycin really isn't standard of care anymore. We have better things like fidaxomicin. And so this is actually comparing stool transplant to fidaxomicin to vancomycin. And you see, once again, that stool transplant is significantly better. However, there are barriers to utilizing stool transplant in the ICU. What's the impact of giving bacteria to a patient who already has an altered microbiome who's likely immunosuppressed? We don't really know. And the majority of critically ill patients at some time receive antibiotics. And if you give antibiotics, you're going to immediately alter the microbiome that you give through a stool transplant. And so there has to be a commitment to stopping antibiotics prior to and after the stool transplant. And this very sobering study recently came out showing that drug-resistant E. coli bacteremia was transmitted by a stool transplant that was not clearly studied in advance, actually killing a patient. And so we need to be careful. But in select cases, the question is asked, can we use stool transplant in the ICU? And right now, the entire world's literature is only 5 cases, but all 5 of them showed an improvement. So it's something for patients without C. diff. So this is something that needs to be studied more, but potentially is something we can use in the ICU. Finally, selective decontamination of the digestive tract, which aims to prevent or eradicate effectively bad bacteria while leaving good bacteria behind. So does SDD work? Well, this is a meta-analysis that's 6 years old of 29 high-quality studies with a really impressive decreased mortality. And unlike a lot of what else I've shown you, this is specifically in the ICU. But essentially, all these trials were done in ICUs with low baseline antimicrobial resistance, mostly in a single country, in the Netherlands, where this is standard of care. And so it led to the question, what happens if there's a higher resistance? And so this came out fairly recently in JAMA, decontamination strategies and bloodstream infections with antibiotic-resistant organisms in ventilated patients. And if you look at the conclusions here, what you see is among patients receiving mechanical ventilations in the ICU with moderate to high antibiotic resistance prevalence, use of SDD was not associated with reductions in ICU-acquired bloodstream infections caused by multi-drug resistant gram-negative bacteria compared to standard of care. And this is in nearly 9,000 patients. So in conclusion, gut dysfunction is common in the intensive care unit. The microbiome is converted to a pathobiome in the intensive care unit and mechanistically plays a role in mortality from sepsis. I didn't show you a whole lot of preclinical studies because I didn't have the time, but the bottom line is there's a lot of convincing preclinical data that the microbiome is not a bystander, but is actually mechanistically responsible in part for mortality. And although the microbiome can be targeted in the ICU in multiple ways, and each of them have some basis behind them, none of them is currently standard of care. Again, I wish I could be with you in person. I so love coming to this meeting. I hope so much for the pandemic to be over, or at least in check soon, such that we can see each other in person in Brussels next year. Thank you so much for the invitation.